My patient is a female, 60 years of age, resident of Gaya, Bihar, homemaker, educated up to 5th standard, by religion Hindu, presented to us with chief complaints of blood mixed foul smell discharge since 2 months. His patient was apparently well 2 months back when she started having vaginal discharge, which is off-white, scanty in amount, thin in viscosity, occasionally mixed with fresh blood. Discharge was not associated with any vaginal discomfort, not associated with any vulvar itching. There is no history of blood in urine, burning, micturition, increase in urinary frequency. There are no bowel complaints. There is no history of any abdominal lump, pain, distension, or jaundice. No history of any hormonal drug intake or topical application. No history of any mass coming out of vagina or any vaginal pessary use. No history of genital trauma, ulcer in private parts, or any surgery. No history of low backache or bony pain. There is no history of loss of appetite, no history of cough, hemoptysis, chest pain, no history of any headache, no history of any lump in breast. Past history, there is no history of any STD. There is no history of any sexually transmitted disorder in patient or spouse, or there is no history of pelvic inflammatory disease. There is no history of any chronic medical or surgical illness. There is no history of any cervical cancer screening in the past. She attained menarche at the age of 14 years. Age of menopause is 50 years. She is postmenopausal since last 10 years. She is married for last 40 years. Para 5, life 5. Last childbirth is 25 years back. There is no history of any contraceptive use. Family history is not significant. Personal history, she belongs to lower middle class according to the Kupuswamy scale. She had mixed diet, sleep-wake cycle normal, bowel and bladder habits are normal. No history of any tobacco consumption. No history of any high-risk sexual behavior in patient or husband. My summary is 60-year-old postmenopausal women, para 5, life 5, with lower middle socioeconomic status, with complaints of blood mix, foul-smelling discharge per vaginum since last 2 months, with no significant past and family history. On proceeding to general examination, patient was conscious, oriented, and cooperative. ECOG score was 1. BMI was 27.8 kg per meter square. General condition fair, hydration adequate, afebrile to touch. There are no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or edema. Pulse rate is 80 per minute, regular. BP is 130/80 millimeter of mercury in right arm in sitting position. Respiratory rate is 16 per minute, thoracoabdominal. Bilateral breast examination, normal, no lump felt, no discharge from nipple. On systemic examination, the chest and respiratory system, CNS system were within normal limit. On explaining, by taking proper consent and explaining the patient, I started per abdominal examination. On inspection, I did abdominal examination after asking to empty the bladder. On inspection, all quadrants are moving equally with respiration. Umbilicus central inverted, all hernial sites free, stria gravidarum present, no other scar mark seen, no dilated veins or visible pulsation seen. On palpation, abdomen soft, non-tender, no guarding rigidity or tenderness, no hepatomegaly or splenomegaly or any mass felt. On percussion, resonant note heard all over the abdomen, no shifting dullness or fluid thrill. On auscultation, normal vowel sounds heard. On local examination, external genitalia, the vulva was healthy, urethral orifice normal, anal orifice was also normal. Per speculum examination was done after putting lignocaine jelly on the speculum, and ulcero-proliferative growth of around 4 by 4 centimeters seen, occupying both lips of the cervix and extending up to anterior vaginal fornix. Foul-smelling whitish discharge was present. Per vaginal examination was done by two lubricated gloved fingers. 4 by 4 centimeter growth palpable in cervix, that is bleeds on touch. Anterior vaginal fornix obliterated. Breast fornices were free. On bimanual examination, the uterus anteverted, no adnexal mass was palpable. On digital per rectal examination, anal tone was normal and mucosa normal. Bilateral parametria free. Gloved fingers stained with stool. Now my summary is 60-year-old women, 60-year-old postmenopausal women, para 5, life 5, with lower middle class socioeconomic status, with complaints of blood mixed foul smelling discharge per vaginum, with no significant past and family history, with normal general physical examination. On pelvic examination, an ulcero-proliferative growth on cervix of 4 by 4 centimeter, extending to anterior vaginal fornices, with no involvement of parametria. Most probably my provisional diagnosis CS cervix, clinically FIGO 2A.
Okay, so what are you going to do next?
My diagnostic workup consists cervical punch biopsy, MRI pelvis with contrast, FDG PET and routine blood investigation.
You are saying that it is FIGO 2A. So why are you going to do a PET scan? You are saying it's FIGO 2A.
Sir,
So why do you want to do a PET scan in a FIGO 2A?
since sir, it is FIGO, it is locally advanced cervical cancer, and there are chances of sir nodal metastasis. So I want to do sir PET scan, or sir, if patient cannot afford, then I will go for sir chest, thorax, and abdomen CT scan, sir, to look for nodal disease, sir.
So which is a better test to look for nodal disease? PET scan or CAT scan?
Sir, PET scan is better than CT scan to go for nodal disease, sir.
Why?
So it has a more, sir, CT scan has a sensitivity of around 50%, while PET scan has a sensitivity of around 85% for para-aortic nodes, sir.
Will you do only PET scan or PET CT?
So PET CT, sir. So the routine blood investigations were within normal limit. Uh, Cervical biopsy was done, which showed moderately differentiated squamous cell carcinoma keratinizing type. MRI was done, so showing my MRI. So this is axial T1 image. This is sir MRI with contrast. It is T1 weighted image uh, with after fat suppression. So here we can see.
We can't see the MRI, we can only see the report.
Sir, I'm showing MRI with contrast T1 weighted image with fat suppression. So trace it from below. This is rectal opening. This is rectum. This is this is vagina, and this is urethral opening. Then we move upwards. We will see that there is a growth occupying the anterior vaginal wall, and growth in the anterior vaginal wall, which is going, and it is occupying whole of the cervix is occupied. It is more on growth is more towards left side, and there is intact stromal ring. It is the stromal ring around the growth is intact. There is no infiltration of the stromal ring, sir. So growth is confined to lower cervix and upper vagina, sir.
So it confirms your clinical diagnosis of 2A.
Yes, sir, it is 2A. Sir, the size which was mentioned was 3.8 by 3.2 by 4 centimeter. So it's 2A1, sir.
What are you going to do next?
Sir, my plan would be to go for surgery. So I will choose surgery. So I will radical hysterectomy plus bilateral pelvic lymph node dissection, sir. So it's my first choice. Second choice will be to go for concurrent chemoradiotherapy.
Why won't you choose concurrent chemoradiotherapy for this patient?
Sir, surgery is the category 1 recommendation for FIGO 2A1 if size is less than 4 centimeter and stromal ring is intact and disease is confined to cervix only.
The
MRI
disease
doesn't
coming out of cervix, right? It's involving the anterior wall of vagina.
so
Then why do you want to?
it is obliterating only anterior vaginal fornix, but parametry is
That's
not involved.
that is still the vagina, right?
So that is an upper vagina, sir. Yes, sir.
So why would you operate this patient and not radiate this patient?
Sir, sir, on surgery and radiation, sir, both had a similar survival rates at this stage, sir.
So in this patient, can you tell me what are the benefits of surgery and what are the benefits of radiation in a lady who's 60 years old?
Sir, radiation has a long radiation has a long morbidity than the surgery, sir. It has a long-term morbidity. So if there is option left for surgery, then preferably I will go for surgery. But both strategies will
You
be safe strategies.
what are the chances this patient is going to require post-operative radiation?
Sir, if this patient, if they are high risk, sir, if sir, there are around, sir, if there are high risk factors, or sir, if there's, sir, since there is no pelvic nodes are not positive, and there is no involvement of parametria, and
How do you
this,
decide which patients are going to require post-operative radiation or not on the final
sir,
list of pathology?
there are certain risk factors, sir, by which we can decide if patient need radiation or not. So there are intermediate risk factor, so which are lymphovascular space invasion, size of the tumor, and stromal invasion. If any of the two factors are positive, then patient required post-operative radiotherapy. If lymph node are positive, if lymph node are positive or parametry are positive or margins are positive, if any one of the factor is present, then patient needs a post-op radiotherapy plus chemotherapy, sir.
Involved when the vagina is involved, the preference is towards radiation, and when cervix is involved, surgery is preferred. Can you think of the rationale behind this?
Sir, there is a study that is done by Landini et al. Sir, according to him, sir, if we do surgery first and if we expose the patient to, if after surgery there are risk factors present, and if we expose the patient for chemoradiation, then the morbidity of the patient increases, because dual therapy increases more morbidity than single therapy. So for high risk patient, it is preferable to go for chemoradiation than for surgery, sir.